Hello everyone and Assalamu alaikum and welcome to today's session. I am Dr. Ismaili and I am really happy to see you all here, investing in your learning and your future. I know OBGY can sometimes feel overwhelming, but trust me, when concepts are taught the right way, they become simple, logical and even enjoyable. In today's class, we will go step by step, focusing on clarity, concepts, and high-yield exam points. So just take a deep breath, stay with me, and let's make this topic easy together and enjoyable. So today I am in continuation of part 3, Thrombocytopenia in pregnancy, and today I am going to talk on a topic which is called gestational thrombocytopenia, and it is also known as incidental thrombocytopenia of pregnancy. So if someone asks you in exam that what is gestational thrombocytopenia, you can say that GT is a late onset, mild, asymptomatic thrombocytopenia of pregnancy with no fetal risk and spontaneous postpartum resolution. So this thing is happy for all of us. Okay, so this can be your one line viva question. Now, this is the most important and most common cause of thrombocytopenia in pregnancy, occurring in approximately 75% of cases of all thrombocytopenia and 8% of all pregnancy. So that's mean the big chunk of thrombocytopenia consists of thrombocytopenia of gestation, that is gestational thrombocytopenia. And if we talk specifically about pregnancy, then at least 8% of all the thrombocytopenia that occur in pregnancy, it constitute gestational thrombocytopenia. As I just mentioned, why this is known as incidental gestational thrombocytopenia? Because it is a benign condition and usually found incidentally later in pregnancy, and there is no bleeding risk to mother or even to the fetus. So the platelet counts are typically between 70 and 100. Please remember this point. This can be your single best answer, and also these percentages are very important in terms of your exam. So now in these patients, the platelet count outside the pregnancy is normal, mean the patient is not going to give you any sort of history of thrombocytopenia before the pregnancy, and it usually resolves 1 to 2 months postnatally. That's why this is known as gestational thrombocytopenia, because it usually resolves postpartum. Now you can be asked that what is it? What is the pathophysiology? So the answer for this is the pathophysiology process is exactly not known, but there are few concepts, few points which you have to remember, that it is regarded that sometimes it is due to physiological dilution due to pregnancy. Second, it is thought to represent an accelerated destruction via an exaggeration of the physiological process across the placenta. And the third, that it can occur possibly via a mild immune response. So in short, it can be due to physiological dilution, accelerated destruction across the placenta, and it can be due to some mild immune process occurring in the body of a patient having pregnancy. Now, what are the features of gestational thrombocytopenia? So diagnosis of exclusion. This is the important point, that GT, that is gestational thrombocytopenia, is usually diagnosed after excluding all other causes of thrombocytopenia. But unfortunately, no specific test is available to distinguish gestational thrombocytopenia from immune thrombocytopenic purpura. And you know very well this topic I have covered in last lecture. So what are the features of gestational thrombocytopenia? That the patient is usually having mild thrombocytopenia, platelet count is usually between 70 and 100 and no associated bleeding. Please note these points. There is no associated maternal bleeding and there is no past history of thrombocytopenia outside the pregnancy. And this thing is very important. Your clinical scenario can occur because that occurrence in the third trimester. So in clinical scenario, you can be given the clue that the patient had thrombocytopenia, decreased platelet count in third trimester. So this can give you a clue for answering the clinical scenario in favor of gestational thrombocytopenia. Now, what is the risk to the fetus in this condition? As I just mentioned, there is no associated fetal thrombocytopenia. So fetus in this condition is happy. Now, another happy thing is that there is spontaneous resolution after delivery, and the important thing is that it can also recur in subsequent pregnancies. Okay, so these are some very important points regarding gestational thrombocytopenia. Please remember, they can help you in solving your clinical scenario and also distinguishing GT from other causes of thrombocytopenia in pregnancy. Now, the exam punch, that to summarize the diagnostic feature, I have brought you just 3 points. Note, it occurs in third trimester. Platelets are usually more than 70 and this is just incidental finding. Mean patient is not complaining of any sort of bleeding or any sort of complaint, purpura, easy bruising, nothing is any complaint to the patient. So there is no diagnostic test except the platelet count normalizes within 6 weeks postpartum. Now, what is the management if you find incidentally the case of gestational thrombocytopenia? For the vast majority of cases, the pregnancy and delivery should be treated as normal. A trial of steroids should be considered when the count is usually less than 70 or between 50 to 70. So only in this condition you can give trial of steroid to the patient. Now, the platelet count should be monitored 4 weekly throughout the pregnancy. Once you declare the patient as a case of gestational thrombocytopenia, then from that point onward, you are going to monitor the platelet count of the patient 4 weekly till patient delivery. Now, affected women do not suffer with bleeding symptom. There is no associated morbidity in the fetus and the risk of the neonatal thrombocytopenia is also not increased. Gestational thrombocytopenia resolves quickly after delivery, but it can recur in subsequent pregnancy and a count should be performed 6 weeks postnatally. So if you are asked a question that till in pregnancy how you are going to monitor the platelet count, that is 4 weekly till delivery. And after delivery, when you are going to have a platelet count repeat, the answer would be 6 weeks postnatally. Okay, and the results are documented. Now it's a time for gift slides. Today I have brought lot of gifts for you because I am happy to share gifts with my community fellows. So the first slide of gift is this one. I have brought a very beautiful comparison between gestational thrombocytopenia and immune thrombocytopenia, because as I just mentioned that there is no specific test to distinguish between these two causes of thrombocytopenia in pregnancy. So let's have a look on this. Now, what is the timing? This is very important that for gestational thrombocytopenia, it occurs most commonly in late pregnancy, in third trimester. But the ITP, it can occur any time in the pregnancy and there is usually a history of thrombocytopenia outside the pregnancy as well, pre-pregnancy as well. Please note this point. Next, what about the platelet count? In GT, the platelet count, as I just mentioned, is just mild decrease. That is, it is usually between 70 to 100. And in thrombocytopenia, it is usually less than 100 and it can come less than 50 as well. Symptoms. patient is not having any symptom, it is just incidentally diagnosed. But in the case of ITP, patient is having bleeding issues. Okay? So past history of thrombocytopenia is absent and it is often present in the case of ITP. There is no fetal risk in GT, but there is a risk of neonatal thrombocytopenia in ITP, and that is 10 to 15%. If you remember from my last lecture, the percentage for neonatal thrombocytopenia in ITP was 10 to 15%. What is the management in case of GT? It is observation only. We are going to treat this patient as a normal patient until the platelet count falls below 50. And in case of ITP, we are initially giving the first line drug in the form of steroid. But in cases of refractory ITP or in cases of severe catastrophic bleeding, we can give IV immunoglobulins to the patient. Now this is very important slide in terms of your exam, in terms of distinguishing between these two conditions in clinical scenario to reach up to the diagnosis. So please note this. Now it's time for next case slide. Now what is the memory hook for this? Gestational thrombocytopenia's diagnosis of exclusion is always mild, late onset, mother only and benign. What is ITP? It is severe, early, symptomatic and affects the mother plus fetus. So this is again a short version of comparison between the two conditions. Now I have brought a mnemonic for this gestational thrombocytopenia, and the mnemonic is late moms. It is something sound interesting, isn't it? So I hope you are going to enjoy this mnemonic. In this mnemonic, L stands for late pregnancy, A stands for asymptomatic, T stands for transient because it resolved postpartum, and E stands for exclusion diagnosis. This condition is diagnosis of exclusion. M stands for mild thrombocytopenia, O only mother is affected, M no management is needed, and S this is safe for the fetus. So again a happy smiley. Now I have brought a clinical scenario for you just to have a quick revision so that we can apply our knowledge on the clinical scenario and we reach up to the diagnosis as I just mentioned. A 28-year-old woman grabbed a 2-para-1 at 34 weeks of gestation is referred after routine antenatal blood tests showing a platelet count of 92. She is asymptomatic with no history of easy bruising, epistaxis, gum bleeding or petechiae. She had an uncomplicated previous pregnancy with normal blood count and no postpartum bleeding. There is no past history of thrombocytopenia, autoimmune disease, liver disease or drug use. Blood pressure is normal and urine dipstick is negative for protein. On examination, she is well, afebrile with no petechiae or ecchymosis. Abdominal examination is consistent with 34-week gestation, meaning there is no element of IUGR. There is no hepatosplenomegaly. Fetal growth and movements are normal. So in this scenario, you can see that the condition was just incidental finding when the patient came for routine antenatal blood test, and patient was asymptomatic and her previous history before pregnancy and even during pregnancy she was absolutely fine and the pregnancy remains uneventful. Now, repeat investigation shows the investigations were repeated, and the repeat investigation again shows that platelet count is 90, hemoglobin white cell count were normal, peripheral blood smear was normal, liver function test coagulation profile was normal as well. So what question you are supposed to be asked in your exam? The first one is, what is the most likely diagnosis? And the answer is gestational thrombocytopenia. List 2 features from the scenario that support this diagnosis. Now you can be asked that justify your diagnosis. So for that you can give the answer that onset in the late pregnancy, mild thrombocytopenia, asymptomatic mother, no past history of thrombocytopenia, normal BP and no proteinuria. Any two you can list, or you can even remember the mnemonic late moms. Now the other question you can be asked, that what is the differential diagnosis that must be excluded. So as I just mentioned, and even I gave you a tabulated form of comparison of GT with ITP. Okay. So the fourth question you can be asked, that what is the most appropriate management at this stage. So the answer is observation only, no treatment is required, repeat platelet count during antenatal follow-up, that is after 4 weeks you can repeat the count again. Next question, is there any risk to the fetus or neonate? And the answer is no. No risk of fetal or neonatal thrombocytopenia. The sixth question you can be asked, that what will you counsel the patient regarding the mode of delivery? So mode of delivery will be the same, and cesarean section is indicated only for obstetric indication. The last question you can be asked, that what is the expected postpartum outcome? And it is very easy. You can say that there is spontaneous resolution of gestational thrombocytopenia within 4 to 6 weeks after delivery. So I hope this question was easy to pick, easy to apply, because the things are in front of you and the topic seems easy for you people, inshallah. So thanks for watching. So please like and follow my channel, and you can give me suggestion in the comment box that which topic you want to study and on which topic I can bring the presentation to you. So till the next presentation, give me a bye and Allah Hafiz.